data supporting, inflammation in MDS actually go back a long time. Actually, I'd say over the past couple of decades. So first, there's a lot of work where inflammation, and so there are what are known as damage-associated molecular patterns, which can trigger what is called toll-like receptor signaling, and actually is a direct driver of MDS pathogenesis. I think there was then sort of some parallel development. There's an inflammatory cell death known as pyroptosis that ultimately triggers what is called NLRP3 activation, caspase-1 activation, and again, this inflammatory cell death where you get enumeration of pro-inflammatory cytokines such as interleukin-1 beta and IL-18 as among others, and kind of a feed-forward pathway based on mutations, very clearly is a central driver of MDS pathogenesis. And I think this has really been elucidated really over the past 4 or 5 years of time. And there's a lot of crosstalk between pure inflammation, this inflammatory cell death, et cetera. And so I think what we know is this is most relevant for lower risk MDS patients. Probably once patients are higher risk, they're more cell death pathways, cell survival pathways, somewhat similar to AML patients that become more relevant. So the hope is now that we understand that this is really central to lower risk MDS patients, can we actually develop disease modifying therapy? Currently, we have none for lower risk MDS, meaning we can't prevent progression to AML. No study has shown to improve overall survival. We've really tried to get away from hypomethylating agent therapy for lower risk. So I think there's a lot of interesting concepts targeting this group of patients. There's some studies, for example, we have investigator-initiated study of canakinumab, which is an interleukin-1 beta inhibitor. There's some other combinations with that agent. There are NLRP3 trials that are entering the clinic as we speak, which I think may be the most exciting target in sort of lower risk MDS. And then the IRACs, which really go through this more inflammation signaling. There is an agent ongoing CA4948, which does have a real name, that has been looked more in high risk MDS and AML, but I think actually low risk may be exciting. I believe Dr. Platzbecker in Germany has a study that does include lower risk patients. And there are some drugs that can inhibit both IRAK1/4 and NLRP3. I think those would be important. My only concern is as we're single targeting different steps in these pathways, is there may be, these cells may be able to overcome it. So you inhibit NLRP3, but IRAK1/4 is still important, or vice versa. And so I think we may have to think about novel combinations to really move the field forward and hopefully, performing the right translationals. But I think the bottom line, very key paramount to MDS pathogenesis, and I think is really the most exciting group of targets for novel therapeutic development in lower risk MDS.